for choosing this Freedom at the Mat Well Chat. To support future episodes, consider purchasing a Freedom Art Mat or vegan leather journal at freedomatthemat.com. We're a nonprofit dedicated to improving the lives of women globally through wellness education and appreciate your support. Now, on to the conversation. This video is for informational purposes only and is not a substitute for medical advice, diagnosis, or treatment plan for you. The views expressed are those of the speaker and do not necessarily reflect those of Freedom at the Mat. We are not liable for any results for elective actions you take after consuming this content. We have the one and only Dr. Danielle Tate of Baptist Medical Group, and she's going to talk to us very specifically about Black maternal health. If you watched the last episode with Moriah Ballard, you understand why it's so important that we figure out solutions to improve the system around Black maternal health. I have a few stats for you, so hang in here with me. Black women in the United States are roughly 3 to 4 times more likely to die from pregnancy-related causes than their white counterparts. And recent data show a maternal mortality rate of about 50 to 53 deaths per 100,000 live births for non-Hispanic Black women, compared to roughly 12 to 15 per 100,000 for white women. This is from the CDC, by the way. I didn't make this up. These deaths include complications during pregnancy, childbirth, and up to about 42 days postpartum. And disparities persist even after adjusting for income, education, and insurance status. Black women are about 3 to 3.5 times more likely to die from pregnancy-related causes than white women. Black women are also about twice as likely as white women to experience severe maternal complications, such as life-threatening hemorrhages, organ failure, ICU admission, and more. And in some states, Black women may be 2 to 3 times more likely to die from pregnancy-related causes than white women. And these gaps are not fully explained by medical risk factors alone. So today, I am beyond honored to welcome to Freedom at the Mat Well Chat podcast, Dr. Danielle Tate. Dr. Tate is a board-certified obstetrics and gynecology and leading maternal-fetal medicine physician. She is the head of the Perinatal Quality Committee at Baptist Medical Group in Memphis, Tennessee. Through her leadership, education, and commitment to improving maternal health, she has helped legions of families and women to have a positive birth experience. We're grateful to have her with us today for a really important conversation that we hope will really change lives. Dr. Tate, welcome to Well Chat. How are you today?
Thank you so much for having me. I am wonderful today. I'm excited to be here and to share. This is probably one of my more passion-forming areas of my work and career, and definitely relevant today to everyone, right? It extends to the entire family, so it's an important conversation. So I'm happy to be here.
It's so obvious that you're so passionate about your work, and we're so grateful for lending us just today for a little time here at Freedom at the Mat. I want to start by talking about why the gap exists. And there are a lot of presumptions and a lot of myths around why the gaps exist. I shared some startling statistics earlier on Black maternal mortality and severe complications in the United States. Will you expound upon the main factors beyond individual health conditions that explain why Black women face such higher risk during pregnancy and childbirth?
Sure. It's very interesting when you look at it because you expect the obvious, right? Is it something to do with their access to care? Is it something to do with financial status, education? But when you equal that out, we still see the rates are startlingly higher. What you quoted doesn't matter status in the United States or social status, family means, all those things don't matter. And so it enters in the discussion about birth equity and the fact that for many Black and brown women in this conversation, they are not seeing themselves in their providers. They are not being fully understood by those caring for them. And it's not a bad thing or anything that has to do with individual providers. It really is a systems level conversation. And that's something that I try to have with my colleagues on a regular basis. We are not pointing fingers at you. We are not calling you any dirty words. It's about how the system of healthcare has set it up for our Black women and how they are received into the system and how they progress through the system and how they are treated that makes the biggest of difference, right? And we hear so much about being heard and about representation. And that is one of the biggest factors when you talk about why are these outcomes still happening in this first world country in 2026, right? Which should not be the case at
Right.
all.
So it's biases. Is that what you're telling me? It's biases.
Correct. And it's really that unconscious level of bias.
Yes. Yes.
We are not really admitting to ourselves or recognizing in ourselves that we may approach patients differently based on whatever it is about them. And we usually start the conversation with the physical appearance that's in front of us.
And I would imagine, I'm just speaking kind of, personally here, that that's no matter if you're African American, Caucasian, Hispanic, like we all come with implicit biases and kind of being more aware of what those biases are. I also heard something different when you were speaking, which was pipeline. So getting more Black doctors. So that we can actually be present and available for our people. So, because I think we're naturally more empathetic to our own people. Would you agree with that?
I would, right? And I'll tell you on the flip side of that, it's not necessarily that we have some code that we can crack with patients that look like us. It's
Okay.
about comfort and safe spaces. And I find just in my own practice, I can create a safe space for certain types of patients that they may not feel comfortable in sharing, in
Right.
asking, in feeling vulnerable, in admitting they don't understand, right? That maybe my colleagues will never colleagues will never be able to do based on how they look. And we can't change gender, race, height, anything like that as we come into the care of patients. But we can recognize that that may be a barrier and understand how to ourselves bring that barrier down so our patients are more comfortable with us regardless of how we look.
So now, from all of your experience, which you have so much at Memphis Baptist Memorial and beyond, what are the red flag symptoms in pregnancy or postpartum that Black women and their families should never ignore? And when should they demand an emergency room visit or call 911?
This is a great question, and I'll tell you why. It's because most times it's assumed that these symptoms or signs are normal for pregnancy or the postpartum period. So we start with those that may trigger the concern for high blood pressure, a headache, specifically one that doesn't get better with routine headache treatments. I've taken Tylenol over the counter. I've taken a nap. It's not getting better. Changes in vision are never normal in pregnancy, so spots, double, blurriness, I can't see. Even if I'm wearing corrective glasses or contacts, they're not working. I can't see a street sign. It's hard to see the TV. Pain out of the ordinary or pain that just doesn't get better as you would expect it to, right? Any level of bleeding in pregnancy we want to know about, whether it's a spot or you are filling up a pad or the floor with bleeding. Anytime a baby's not moving in the womb as expected, so the routine that's expected, we want to know about any level of leaking. Basically, what I tell my patients is ask and make sure. You're never a bother to just confirm and would rather you confirm with the healthcare professional, whether that's a doctor, a nurse, medical assistant, versus maybe searching online and trying to figure out on your own.
Dr. Tate, as you're speaking, I appreciate everything you said. And I think you offered, of course, really valid things about bleeding, pain, vision, high blood pressure, headaches. But I want to talk about something that is even under the surface there. We as Black women, we have a really high tolerance for pain just because many of us, the way we've been treated. So we kind of, whether we do or whether we don't, many of us don't want to ask for the help. We don't want to feel like we're being a bother. Or if we do, it's like, oh, just you'll be okay. What would you say to Black women who have a hard time advocating for themselves, who they just can't find the courage to be like, oh, I got a little headache, I'll be okay. Got a little bleeding, I'll be okay. What would you tell them to encourage them and embolden them to make that call?
I would first start by saying let's just verify the okay. I would rather you hear 100 times, yes, that is perfectly normal. That's expected when you're pregnant. That is expected at this point in pregnancy than to just assume. And I tell you, a lot of that in my experience is rooted in being dismissed previously in the healthcare system. So you've been made to feel like you are bothered, or you've been
Right.
made to feel as if your problems are not at all valid
Yep.
or worthy of time. So you come into this situation of pregnancy feeling and remembering those things, and then you forget that no, this is a new situation, new set of doctors, new set of health care related concerns. And oftentimes, when you realize that to start, you get a different approach as long as you, like you said, bring it up and let it be known what's happening. Also, there's a way to be curious, right? And I would say this to any patient, regardless of how you look, it's a way to ask and be curious without being offensive in a sense, right? I'll tell you, we're human as doctors. We have our sensitivities and things that will definitely lean into maybe someone being more off-putted by your question, but sometimes it's just a matter of clarification. I just want to clarify. You said my pain was okay, and this is something normal versus, you need to do something about this, or not saying anything at all until the bad thing happens. And then you start to retrace steps. And in my mind, as your provider, I'm saying, wish you would have said something days
Right.
ago, hours ago. We may be in a different spot in this moment, right? Not to blame anyone, but it
No.
does take something as practice. And what I find a lot of times in my patients is when you look over their life, they're really not being heard in a lot of aspects of life, not
Correct.
just the healthcare, right? Whether it's family dynamics, partner dynamics, work
Yeah.
dynamics. And so that's just kind of how they've learned to survive, is to
Right.
kind of shrink away. But this is where you're entering in a situation where you are the most important part of this team. We do, the fact that we're honoring your wishes and keeping you at the forefront of understanding so you make decisions that are best for you and your baby are the most important thing at the end of the day, right?
And Dr. Tate, thank you for that, right? Because I really want
Right.
people to listen to this and feel emboldened, or if they have children that are going to have children, or nieces, or themselves, or sisters, for them to share this with them. But I also want to talk about how I think that there is this notion that we do shrink away. We really do. We lose our confidence along the way of kind of being shunned over and over till we have to go and find that confidence, which is why I wanted to ask you those questions. So let's talk about in the delivery room, right? So now we're about to have the baby, right? We're talking about life or death. What are some practical strategies that Black women can use, and their spouses, daughters, sisters, and family members can use
Mhm.
for around support when they feel their concerns are being dismissed in the hospital or clinic?
And that's a great question because I see this a lot in thinking, you're about to have a human exit out of your body. I cannot tell you you don't feel pain that you feel or you don't feel discomfort, right? And I think a lot of it starts with having a birth vision. Now, I know people talk a lot about birth plans, and I'll tell you the running joke in the obstetrics world is make a plan, we're bound to break it. Just because the simple fact you're very strict. But what a vision does is give you fluidity, but also having an idea for all of us to hold on to of how you want this experience to go. Saying that I'm flexible in the case that it's becoming dangerous and we need to shift, or something may work better than the vision I had, but it allows that conversation. So basically what I'm saying is to, at the forefront of things, have this conversation at the beginning. And where it really needs to start is before the day of delivery, so that your doctor's on board, one, or midwife, whoever's delivering. Also, so you know what the hospital has to offer. Because a lot of times I'll have patients that say, I want a water birth. And I'll say, well, in our area, there are no hospitals with water births. So let's talk about what that looks like, because I don't want you coming in being disappointed, or that interaction then changes because you had this vision in mind that we weren't able to address, right? And
Right.
then kind of understanding what the hospital has to offer in general as you build that plan. And then also open communication. I'll tell you in my experience, what I find is a lot of, unfortunately, my Black families are very quiet.
Mm.
And it's when I come in the room, then they're vocal. And I said, I understand, safe space, we're talking. So
Right.
then I, definitely will go and advocate for them with the other healthcare providers. But what I usually hear is, we didn't realize we were coming across that way, that we were being dismissive, that we weren't honoring what they were saying. Why didn't the patient tell me that? I've been in the room 10 times and they said nothing, But again, I get it. It's not as easy as a practice as it is a saying
Yeah.
to be able to speak up for yourself and to be heard. Definitely corrective action in a respectful way.
Right.
So, one of my pet peeves, and I'll say it, is I really, really do not like for people to say baby daddy. That's baby daddy over there. And I'm like, no, that's her fiance, that's her husband, that's the father of the child. It's just the connotation with it. And so I tell patients all the time, don't give people the liberty don't introduce your husband as your baby daddy, right? Or make sure he's being acknowledged in the room.
Pardon me for interrupting you. You're saying
If you're enjoying this conversation, consider supporting Freedom at the Mat with the purchase of our luxury art mats or vegan leather journals at freedomatthemat.com. We're a nonprofit dedicating to improving the lives of women globally and appreciate your support. Now back to the conversation.
That's baby daddy over there. And I'm like, no, that's her fiance, that's her husband, that's the father of the child. It's just the connotation with it. And so I tell patients all the time, don't give people the liberty don't introduce your husband as your baby daddy, right? Or make sure he's being acknowledged in the room.
pardon me for interrupting you. You're saying you have a disdain for that when your medical professionals call baby daddy.
Correct.
I can't even imagine. I can't even.
So, and I get it. I know it's a colloquialism and we use it a lot in a lot of sayings, but it's about acknowledging the relationship and the importance of the partner being in the room, right?
Yes.
And just the fact that the partner gets acknowledged in the room. They're
Right.
not a piece of furniture. They're there. What is there? And, getting them involved in the conversation of the plan and the understanding of things. Just acknowledging goes a long way is what I try to teach my colleagues. Acknowledge the other people in the room because these are the people that are usually helping her guide her plan.
Right. Right.
And I get it. It can take just a tone, a voice, a look, a preconceived notion where we're in healthcare as a person who has to get healthcare myself.
Right.
Coming into the situation, being perceived as having an attitude or a problem or being difficult, right?
Right.
And things like that. I really wish I had a script that says this works every time. But again, I think coming at it in a sense of making sure they understand that you're just trying to understand what's going on with your care so you can make good decisions goes a long way.
You just mentioned about the care team, right? So when you hear care team, I think for some, especially young mothers, that may feel a little bit lofty and perhaps unattainable. Can you talk to us about how someone can choose a care team? Is a full care team necessary? What does that look like beyond an OB-GYN?
And you're right. Some people limit that to just being your delivering provider or your healthcare provider during the pregnancy, which again can either be a physician, a nurse practitioner, or a midwife. But it extends, right? You have nursing staff both in your prenatal care journey and in the delivery and postpartum journey. You have medical assistants that oftentimes assist your provider. And then we talk about the elective, quote unquote, support, which are like doula support or birthing support as well, that are really great in the space of helping you to navigate support. And I will tell you, with so much change in the world, as someone who is not from the Mid-South, I understand this completely. I have no family support to have a child, so a doula makes sense, right? Or just family dynamics where you kind of don't see the grandma that takes care of all the kids while everyone's at work, right? Grandma's probably still working,
Right.
or in some instances, maybe still having children of their own. How do you have that support that's allowed to come in and really help you understand and navigate the system? So I'm all about doula support, birthing work support as well. And then you have other extensions of cares like caseworkers, insurance provided level of care, social work, things like that. Now, everyone's support team is going to look different, one in who's there and how they are involved in care. But what I find most times is that people don't realize the support is available to them and what that looks like. And I'll tell you, for someone who takes care of women and delivers them and knows that at any given time I could have several patients laboring, having a birth support person to fill in that gap is very helpful.
Okay.
Right? To help through the labor pains, to help breathing exercises, whatever that is, or even in the office to say, okay, well, listen, by the limitations a lot of not our doing, we may only have a certain amount of time with you in the office, but now I have an extension of my knowledge and support through my staff as well as outside support to help you understand how to navigate your pregnancy.
I appreciate that. I think, from what I understand, you really do need more support than just the OB-GYNs, the doula, the midwives. It's an entire care approach that you need to plan for. Beyond one-on-one medical care, what changes in hospitals, clinics, and policy in places like Memphis, which is my hometown, would most reduce Black maternal deaths? And how can our listeners help push and advocate for those changes?
So I think one of the biggest things is addressing, you mentioned it, implicit bias, especially when it comes to knowledge as a provider, right? Because there are a lot of things deep rooted in our knowledge as providers that are just false. You mentioned one already, which is Black people experience pain differently.
Yes.
And that in itself could change the experience tremendously. I will say that as systems in Memphis, especially in the state of Tennessee with the work that I do, the people are out there doing the work and they're genuinely wanting to see success and to see equity happen, regardless of what they look like in their background. They're really striving for safe care. And that's what really matters. It
Right.
doesn't matter who it is, it's about that the care is safe consistently everywhere you go. And I will say the hospital systems that I am familiar with, that I work in, that I have experience with, are all doing and striving for just that. But it is an ongoing process, right?
Right.
Hence the word practicing medicine. It's always an ongoing process. So what works today may not work in a week. What works in a week may need to be altered in 2 weeks. But the goal is to always be knowledgeable that we have to keep safety as the forefront and everything else falls into place. Now, for Black and brown people and being in Memphis as part of the state, that's where most are housed. We definitely have this conversation on a regular basis about what that looks like, right? And again, it starts with understanding each other
Right.
and then making sure what we have in place works for the people that we're trying to support and take care of, because what we provide may not be realistic in the life of those that we care for on a daily basis. And so with that, there's a lot of partnerships with wraparound services we have, and that is in a lot of communities. So you look at even just community-based therapy services or doula services. I encourage anyone who has any sort of birthing experience. You don't have to have a medical background.
Mm.
You go to the courses, you partner with the providers, and then you become that support that the person needs. And a lot of that we see lacking again in our communities because of just the dynamics of everything, right?
Right.
There's always an opportunity to be the community or patient voice on a level of all of the state agencies and national agencies. Specifically, TIPQC that I work with, they are absolutely about patient partners coming in and having a patient voice as we plan the future and we work towards improvement. And they call for that from the hospital systems across the state. You need to be having the active patient voice there, right? And having that community build up around the patient as well. And then reaching out, there's always things. I think, one of the biggest issues is knowing where it is and how to connect to it. And it's really not as difficult as you think to be able to partner and bring your voice and your help to the situation.
Dr. Tate, I wanted to go back to when I made the comment even earlier and said Black women have a higher tolerance for pain, and then I kind of retracted it. It's fascinating how you can even be a person of color and have bought into that concept, right? But what I think, and this is just totally, I am not a medical professional at all, is that those of us who are on the patient side, we don't believe that we're going to be taken seriously. So we end up experiencing a higher tolerance of pain, having higher pain experiences. We're just
Right.
like, I'll just take a Tylenol. I'll just do whatever. Because if I
Mm.
go to the doctor and they dismiss me, then I would have wasted my time. I would have taken off work for nothing. So I'm just going to do X, Y, Z. So I think that that's kind of what happened on the patient side is that we experience higher pain because we just don't think we're going to be taken seriously when we go to doctors. So we appreciate doctors like you who are empathetic and that provide those safe spaces for us. So for anyone listening now, or, whether it's them having a child or someone they know, how can they get a doula? And is it expensive to do so?
So there's different levels. Here's the great news. On the government level, specifically state, they're recognizing the importance and the difference that doulas make, especially with closing the gap of maternal mortality. So we are now seeing the infancy of support on the level of insurance companies and state funding and grant funding for that. So the first thing I would encourage someone to do is check with your insurance company to see if there's a level or if they are connected with some sort of doula services that may be at a discount or fully covered. And the second is really most are prorated, meaning depending on how involved you want them with your care, depends on how much they cost. You may just want them there for the birth, and that's all. You may want them there just for postpartum to help you figure out the first bath and get a break every once in a while. You may want them at every visit. They come in varying ways. And as someone who may be looking to be a doula, you can hyper focus into certain areas of care and that be your specialty care. Right. And with it, you can expand into lactation specialists and then it can build to more and more. Right. So I don't want anyone to ever feel they're limited in how they can support a birthing person. It just depends on how they feel their skills and passion and all that they do is going to be most helpful to the person.
I really appreciate you spending some time on the doula piece because, as you referenced, there are many of us who do not have familial support for many different reasons. It's not always somebody who had a child out of wedlock, right? And I think that's maligned still. It's not just that. You could be in another city without that mother, you're the grandmother of the child to get the kids up to school. There's so many reasons why, in general, there are many of us who could just need some doula support. You may have a partner that may not be supportive. You may have a partner that travels a lot. Or, like many women these days, they're choosing to have children later and without partners, like just having them with friends or, like brother friends kind of thing. So I think knowing that there is support available to doulas is very helpful. So I want to talk about the personal responsibility. What are the most important steps that an expectant mother and her family can take early on in the pregnancy to help create a healthy pregnancy environment and a safe delivery? What can she do?
And this is a great question because there's so much that happens in pregnancy unwanted that has nothing to do with the person per se, but the fact that there's pregnancy involved. But what can we do? Absolutely, as cliche as it sounds, as simple as it sounds, prenatal care. If I can't see you and get to you as a provider, I can't catch things or pick up on things early. I'm not able to make sure we are monitoring and doing our part to make sure nothing turns to an unwanted. Taking your prenatal vitamin is super important, and that could be the version that's a gummy. That could be, the version that is the off-brand at a store, all those things. I would say be very careful with online, and that's a conversation for a different day. But as well as that, just making sure we're not doing the obvious things that we know contribute to bad outcomes, like smoking cigarettes, right? Or, diet is one thing, and that could be a whole nother podcast again on itself. Being educated, right. But being educated just about what to expect. And I find, I'll tell you in my career, what a lot of it comes down to is not having the knowledge to recognize when there's early change. And a lot of that you're going to get educated on by seeing providers, right? Connecting and even to community support. I know here in Memphis, we have great free childbirth classes. Come in, get educated, bring your partner. There's some actual resources for dads, new dads and dads to be, things like that as well. But I think what happens too is as you get to understand pregnancy more, and the expectation, it starts to empower you to be able to advocate for yourself and not just be accepting of whatever you're told.
Correct.
Mhm.
Correct. So that care is going to be really critical
Yeah.
to kind of be connected to your body and your doctor and get validated around how you're feeling and knowing your body. Dr. Tate, so from what I understand, and please correct me, and from what I've read, there's still instances of fatalities with women after birth. Is that correct?
That is correct.
Okay. All right.
And so we are naming that roughly the fourth trimester, just so it gets as much notice and light as being pregnant. And a lot of it ties into the fact now we have this shift in priority, right? Every great mother that has a baby is going to start focusing on that baby. And then it shifts to, well, I just won't go to my appointment postpartum. I need to take the baby to the pediatrician. Or I just won't get any sleep. I need to take care of the baby. I need to be super mom. I need to clean. I need to cook. I need to do everything. And then they slowly start to not pay attention to what's going on with them. That's one. I'm not saying it's all a patient level thing. And then two, what I find a lot of times is the shifting in the mindset of the healthcare system where there's no baby there. So clearly that's not an issue, right? Oh, well, you're 5 weeks after having a baby. Clearly this blood pressure thing is not a thing anymore. Or that headache is probably just because you're tired. And a lot of times I'll find patients discuss things about being dismissed in the system postpartum because we write it off as just postpartum changes. Well, you're not sleeping. You're worried about the baby. Everyone's a little anxious. It's the baby blues, all the things that you hear, and we miss the mark of saying, no, she said she can't breathe when she walks. That is not normal for someone who's just had a baby. We got to look and realize her heart is failing and those things. So it's really about being persistent. You don't have to at all be aggressive or off-putting in your persistence. But I tell anyone, if it does not sit right with you, the answer you're getting, you should then seek a second opinion, right? We talk about that all the time in medicine. And then there's the shifting of understanding who should be taking care of you postpartum, right? Traditionally, we say your OB-GYN is there for you the first 6 weeks. But then there's this shift of, well, I'm not pregnant, so I went to the emergency room, and now I'm entering into an emergency room that doesn't deal with pregnancy versus a labor and delivery that does. And just by general nature, those providers may not think first, she was just pregnant. This could be related to that. And things get off-putting, right? Or we're shifting out and your OB-GYN is saying, well, it's been 6 weeks, go back to your primary, and you don't have a primary to go back to. And now we're seeing those changes, which is great because most states like Tennessee have now extended healthcare up to a year. So now we can transition our patients back safely into their primary care without them having to worry about bills and being extended financially to keep their health going. And then lastly, what people don't realize is a lot of things that start in pregnancy aren't an immediate fix with delivery. And so we need to continue to monitor, work on, make sure things resolve. One example is preeclampsia, which is high blood pressure related to pregnancy. It can linger for up to 12 weeks after having a baby. And that may require seeing a doctor, making sure your blood pressure is monitored at home, adjusting medications until things are back to normal. So it's layered, but a lot of times what we have to do is just remember the time period in the weeks after delivery are just as important as the pregnancy weeks.
That's what I wanted you to tell us, because I think people are like, oh, the baby's here now. We can go back doing everything. It's like, no. There's still some sensitivity. And the final thing I want you to define for us, I know this could be a whole other episode, but I want you to tell people, define what is postpartum, right? And that postpartum depression or experience and why that happens, because I remember my sister telling me something that happened with her in postpartum, and I was like, for real? Right? So for those of us who don't understand it and don't believe that it's real, can you tell us more about what postpartum is and what we might expect for the new mother and from the new mother and how we can support her?
Sure, absolutely. Well, we define the period first, and it's up to the first year in a lot of situations after having a baby. Now, the first 6 weeks are the most important, because that's when you talk about hormonal changes and we're getting our body back to normal and the womb's changing back to normal and I'm maybe getting a cycle back, all those things, right?
Okay.
So that's why you kind of hear about the first 6 weeks. Now, within that, there are a lot of things under that subheading. The first, which is what you mentioned, is mental health changes, right? And a lot of times postpartum is synonymous with postpartum depression.
Right.
We don't want to forget, though, anxiety, OCD, PTSD, all those things are very likely to happen and they could be linked to the pregnancy, right? If I were delivering and all of a sudden my team ran in and said we didn't do an emergency C-section, I'm probably going to have a little post-traumatic stress after that in the way of going through that traumatic event and then no one really addressed it because me and my baby are healthy, right? Or let's talk about something even more simple. I really want to breastfeed and I can't. It's going to send me into a different headspace. And it's going to look very differently for me versus my friend who is overproducer and I feel less, and that could then add to it. And so it could be a lot of layers. And there are also medical conditions that can contribute to your mental health, like your thyroid. If it's not working well, it'll absolutely make it look completely like postpartum depression, right? And so what we've learned in the world of obstetrics and gynecology is we need to make sure we're checking in more. So really the rule now is you should be seeing your provider 1 week after you deliver. They're wanting to check on your blood pressure. They're wanting to check on how you're healing from delivery, and they're wanting to check on your mood. Because baby blues are a thing. That's just hormones changing, right?
Right.
But they are not a lasting thing. They are not an impact my ability to function everyday life thing. That's when we enter in the realm of anxiety, depression, and other things that we need to look into. And then there's the 6-week checkup. That's the getting you back to normal completely. And then now there's even conversations about going even further for the OB-GYN into maybe month 2 or 3 after having a baby just to make sure, right? And then we talk about postpartum by way of let's go back and talk about this pregnancy. How did it go for you? Did something come up that you weren't planning, like diabetes or pregnancy? And what does that mean for your long-term health, right? How did your birthing experience go? Let's talk about birth control. A lot of people don't realize pretty much everyone's back to being fertile a month after having a baby. And guess who most people haven't seen a month after having their baby? Their OB-GYN. And more than likely, we have quite a few that will show up at their checkup pregnant again. Was that your plan, right? Let's talk about timing, because we want you to give not only time for your body to be ready for another pregnancy, but your family, right? And not for you to have feelings of guilt or shame because you're pregnant again, and how am I going to divide myself between 2 littles? Or maybe I already have children at home and it's already a struggle. So it's a lot of levels to that postpartum period that makes it quite complex, and more than we often give credit to because of the nature of pregnancy, right? You first have a patient who doesn't go to sleep. It's a pretty routine every day. We're expecting women's bodies to do this kind of thing, having a baby. And then all of a sudden, we're expecting motherhood to come naturally. And that's not a case too. Or we're expecting every recovery period to be straightforward. That's not the case either. And so what I tell patients a lot of times is to allow in help. So yes, I know you want to be super mom, but let someone fold the clothes while you go take a nap.
Right.
Let, a family member come over and watch the child. Turn the phone off when the baby sleeps and you sleep too. Tell anyone that will call 911 thinking you're hurt, and let them know you're taking a nap, and you go and you rest and you take care of yourself. Don't feel guilty to take time for yourself, because we know most women are the head as far as how the family moves, not financial support. And if they're not doing well, everything else is not going to do well. And so what I tell support is just find a way, because I'll have partners say, well, she won't let me do anything. I can't do anything. Just find something, one little something, and start there.
Right. You'll be strong.
You'll be strong. We're strong together, Hey, I'll unload the dishwasher. That was one thing that I could do right, right?
Right.
Or, get out of your hair or whatever it is, right? But it's a lot of layers of support that's needed postpartum that oftentimes, again, is put to the side because now the baby's out of the body and everything's great.
Thank you. Dr. Tate, we appreciate your time. I know that you're a very, very busy doctor, a leading doctor in this maternal health space. And I know that there are people who might want to get more resources. Where might you direct people if they want to get additional information about anything you've shared today?
So the best place to start is your national level. So there's like Hear Her campaign, which will tell you about ways to connect for birth equity, as well as a lot of the national websites will take you to your local. They connect into your local websites. Our state level, TIPQC, as you mentioned, has a lot of ways to connect into community-based ways to be involved in care, or from the patient side, getting information about what's going on in the state and what the opportunities are. And those are great places to start. March of Dimes is a great resource. I mentioned our organizations, which are ACOG and SMFM, which are our national organizations that then have local chapters down to the city level as well. And then just from there, usually you'll find your wraparound support. And our good old friend social media is a lot of times where you'll find the ability to know what's there. I'm not saying it's going to always give you all the information, but it's a great way, we recognize where people's attentions are these days.
Yeah.
And so we know that you can find ways for the advertising of things that are more community-based as well.
Well, Dr. Tate, I appreciate you so much. And to everybody listening today, we will detail all of those resources below in the description. Dr. Danielle Tate, thank you so very much for dedicating your life to delivering so many babies and for supporting Black maternal health in particular, but maternal health overall. May God continue to bless you in your practice. We also thank Baptist Medical Group for lending you today. We are grateful that we have an understanding of the situation, and now we have information to help us become more vigilant and better advocates for ourselves, for our children, our daughters, our nieces, our aunts, our mothers. And I'm grateful. We're really grateful to you. Your insight reminds us that Black maternal health is not just a medical issue, but a matter of advocacy, awareness, and community support. We pray that every mother, baby, and family is surrounded by the care that she needs. We're so grateful you talked to us today about doulas and the compassion and the knowledge to have a really healthy birth journey. Thank you again for joining us today on Freedom at the Matt's Well Chat podcast, and we'll see everybody else soon. Ashe.
Thank you for choosing this Freedom at the Mat Well Chat. To support future episodes, consider purchasing a Freedom Art Mat or vegan leather journal at freedomatthemat.com. We're a nonprofit dedicated to improving the lives of women globally through wellness education and appreciate your support.